Thank you very much, uh, chairpersons, and thank you, Dr. Ellen Khanna, for inviting me to talk on difficult anatomy. And I'll show you one case where is it an exception or the rule. This is a 79-year-old male, right-handed, sudden weakness of the right half of body with partial recovery. And as you can see, the CT scan, the MRI shows that the right ICA is occluded. There is no flow void. The left ICA is patent, and he has no major infarct. When we did the angiogram, this is what we saw. The right ICA is completely occluded in the neck. The left ICA is seen as a small streak here at the carotid bifurcation, the external carotid artery and the internal carotid artery here. So the question was, what should be done? He had come with a stroke that had partially recovered, and this is what the anatomy was. So how many people would like to stent this case? Hands, please. Right. So what we did an arch angio also, and this is what the arch angio shows. The arch angio shows a bovine arch here and an aberrant origin of the right subclavian. The right subclavian arises, goes behind the esophagus, whereas a bovine arch, this is the common carotid on the right side, and this is the left common carotid with an acute origin. The arch was type 2, and you can see something similar to this picture, what Myla said. And when we did other views, this is what the anatomy was. So once again, would you like to stent, or what would you like to do? This is an old case, almost 8 years back when we did this. But today, the whole scenario would be different. Anyone willing?
I think stent is still an option.
Stent
Okay,
is
of
still
course,
an
it depends
option.
upon the surgeon involved, and our treatment. We can obviously discuss the issues with them.
Absolutely.
But it's not that it's excluded in the present condition.
Absolutely.
Yeah, you could access that common carotid in the neck and stent directly
Yes.
through that with a short sheath.
That is absolutely right. So this is what the evolution was, and we see that only in about 4% cases there is an aberrant origin of the subclavian artery with a tortuous arch and an acute origin of the left common carotid. With the right ICA occluded, the chances of having a major complication on a dominant hemisphere are quite high. So we attempted, and this is what the intracranial circulation showed. The vertebral artery through the PCOM supplies the right ICA territory. The left ICA territory is supplied directly, and both ACAs get their supply from the left side. The MCA is also there. This is the right common carotid. The external carotid is there, and there is faint filling of the supraclinoid ICM. So on examination, this is what it was. The right common carotid artery was occluded, or the internal carotid artery was not getting its supply. The left side was 99% stenosed. Both ACAs fill from the left side and the MCA territory, and there is a PCOM also. So the PCOM is there on the right side, which takes care of the right hemisphere. So what are the risks now? The risks in such a patient would be if there is hypotension during the procedure, if there is thromboembolism during the procedure, the plaque is partially calcified, and the access difficult. Considering all these options, a viable option would be to try and do a stenting today. But if the anatomy is difficult, then I think surgery would still be an option, and it should be considered. And this is exactly what we did. We attempted. 8 years back, it was extremely difficult to negotiate a a stent across the stenosis on the left side. Today, it will be easy because of the 018 and 014 systems that are available. And once the wire crosses and the stent can be placed, then it is not a very difficult thing. Going from the brachial side is also very difficult in this case because of the aberrant origin of the subclavian artery on the right side, as well as on the left side, it will be a very acute angle. But people have attempted it, and they have successfully deployed stents across. So the patient was subjected to surgery, and endarterectomy was done, and this is what the plaque was there, and the patient did well after surgery. So the moral of the story is that in difficult anatomy, age, the anatomy of the disease, the tortuosity of the arch, as well as difficult access, I think surgery still stands true, and it should be considered in any case which can be stented. I'm not saying that this cannot be stented now, but yes, you have to weigh your options and also the risk of complication in a case-to-case basis. Thank you.
We just have time for one question, please. Yourself.
Doctor, you have presented a nice case and really a difficult anatomy which can be, which we could approach by intervention. Now, before we were discussing, you were talking about it. You see, I believe that the surgery is still the choice of treatment in carotid artery. And we are still interventions, we are fighting actually to find our place there. So, I mean, carotid artery surgery is still taken all over the world as the choice. Though we are now very successful with the intervention around over 90% of cases. Thank you.
Thank you very much. And